Ladies and gentlemen, good afternoon, evening and night from WHO here, headquarters here in Geneva. My very warm greetings, and it's a wonderful opportunity this morning again to be joined by ministers of the health from around our 194 member states for this COVID information session, which will feature 6 presentations from member states around the WHO regions. As per usual practice, we will have an introduction from the Director General. We will then have an update on WHA 73 from Executive Director Governance and External Relations, Jane Ellison. Many of you are very interested in progress towards the WHA, of course. Then on to our 6 presentations from today: South Africa, Chile, Iran, Sweden, India, and Fiji. That will be then followed by questions and answers from the Secretariat. A reminder, though, that the primary purpose for today is for member states to hear from other member states in terms of the preparedness and response to COVID-19. And I would ask that the first round of questions from participants be directed to those presenting member states today. We do, of course, have the Secretariat on hand for any specific questions, but I repeat, the focus will be directed towards the countries who are presenting today. With that, I would like the opportunity to ask Dr. Tedros, the Director General, for his opening remarks. DG, you have the floor.
Thank you. Thank you, Tim. Honorable Ministers, Excellencies, dear colleagues and friends, thank you so much for joining us in today's briefing. As you know, during Member States briefing, we take the floor, most of it, but today we're reversing it. So I will not take more than a minute of your time. Maybe if I have something to say, I will say it after your presentations. As you know, many countries are now doing their best fighting this pandemic. And we have experiences from many countries now that can be shared. And WHO, using its convening responsibility, have now brought you together to share your experience. And we're glad that those countries who have already agreed to present are ready for the presentations. And I would like to use this opportunity to thank South Africa, Chile, Iran, Sweden, India, and Fiji. So we go straight to the presentation because we're here to really listen to you and all member states also to hear from you, the other member states who are not presenting today. So back to you, Tim, and wish us a successful deliberation. Thank you.
Thank you very much, DG. Just before the presentation, we've got a couple of remarks on the WHA process, and several member states have asked us to update on that. So Jane was going to make that brief introduction. Is that in the end? Okay, DG, we'll follow that.
Yes.
Okay.
So let's focus on the presentations, and then we can do this. Yeah.
Certainly, DG. Not a problem.
Thank you.
Thank you very much. We have been informed that the Minister of Health from Chile has been called to a meeting and would therefore be able to take the floor first in order to give that country's presentations and that country's response. And so if you would permit, I should therefore like to give the floor to the Honourable Minister, that is Dr. Minulik from Chile. You have the floor, sir.
Voy a hablar en castellano. Muy buenos días, hora nuestra, a todos ustedes. Lo primero que quiero decir a nombre de Chile y de la región de América Latina en particular, es expresar un profundo agradecimiento a la Organización Mundial de la Salud, al liderazgo del Dr. Tedros, que nosotros avalamos y agradecemos muy profundamente el trabajo que está haciendo la organización frente a esta pandemia, a este desafío epidemiológico del cual tal vez el único recuerdo parecido que haya en la historia reciente es la mal llamada gripe española por virus de influenza A H1N1 del año 1918 y 1919, que ciertamente cambió el curso de la historia. Para los países en general, creo que ha sido bastante complejo tomar en serio, tomar en cuenta lo que esta pandemia significa. Muy al principio fue tomada como un tema solo de salud. Hoy día sabemos que el impacto que esta pandemia, que seguramente va a durar varios años en olas, en ciclos, va a producir un daño de proporciones históricas, catastróficas en la humanidad, y esto no solo por la gente que va a enfermar o está enfermando, o peor todavía, los que fallecen a causa de esta enfermedad, sino el tremendo impacto en los determinantes sociales de salud, acceso a la atención primaria de salud, acceso a medicamentos, acceso a cirugías, muchas de las cuales ya hemos debido postergar. Estamos frente a un enemigo monumental, y en ese sentido el rol del liderazgo sanitario mundial representado en la OMS, pero en cada uno de los participantes de esta sesión conjunta, es un llamado muy exigente al heroísmo, a la generosidad, a trabajar muy duro y a tratar, insisto, de impedir que el daño que esta epidemia está produciendo sea aún mayor. Como países, nosotros vemos que esta pandemia ha tenido un claro desarrollo de vector desde Oriente hacia Occidente. Hoy día el lugar del planeta más afectado por el virus SARS-CoV-2 es Estados Unidos, tiene prácticamente un cuarto de los casos y de los fallecidos en el mundo, y vemos con preocupación que se está empezando a configurar un segundo vector, ya no de este a oeste, sino de norte a sur, que en el caso de muchos de nuestros países va a coincidir con un invierno que normalmente produce situaciones muy complejas para otras infecciones respiratorias como la influenza estacional, por ejemplo. A América Latina en particular, este brote llegó a principios del mes de marzo, primero, como es obvio, como casos importados en algunos países del cono sur latinoamericano, fundamentalmente desde España e Italia, y en otros países directamente desde China. Desde entonces, los países hemos respondido con mucho sacrificio y esfuerzo, con una inversión pública enorme para nuestros recursos, y nos hemos concentrado en desarrollar testeo y en el aislamiento de los pacientes, que ha sido extraordinariamente complejo para todas nuestras naciones. Y en ese sentido, insisto, manifestando este apoyo y esta voluntad, creo que hay algunas dificultades o algunos procesos que requieren la máxima atención en breve. La primera es cómo masificar el testeo mediante PCR o exámenes de anticuerpos para poder realmente seguir adecuadamente la estrategia de testear, tratar, aislar. Nosotros hoy día como Chile tenemos una capacidad instalada para hacer 12.000 PCR diarios. Podemos llegar a 18.000 diarios para una población de 18 millones de habitantes. Estamos reportando aproximadamente 400 casos nuevos por día, y el número de enfermos nuevos se ha estabilizado en esta cifra entre 400 y 500 diarios desde hace aproximadamente 11 días ya. Tenemos un contingente habitual, cotidiano, de aproximadamente 100 personas en unidades de tratamiento intensivo estable, conectados a ventilación mecánica, y evidentemente el recurso ventilador mecánico es también una situación muy compleja para nuestros países. En ese sentido, nos ha llamado la atención durante los últimos días que hemos empezado a hacer PCR no solo a los pacientes con síntomas, sino a sus contactos estrechos. Y nos hemos encontrado con una positividad en los contactos estrechos, que quiere decir viven en el mismo techo, comparten un trabajo muy cercanamente, de alrededor de un 30% de personas que no tuvieron síntomas o no tienen síntomas y tienen un PCR positivo para coronavirus. La próxima semana vamos a empezar a testear mediante IgG, inmunoglobulina G, a población asintomática para tratar de entender seroprevalencia.
Understand the seroprevalence of this illness. And there is a Chilean initiative in this domain, and it is the following that I would like to see if you have any opinions or any thoughts on this. We have thought that perhaps it would be cautious to give each person that has medical history of demonstrated coronavirus through a PCR test and that has been in quarantine between 14 and 28 days, we thought that we could give them certificates, which we would call discharge cards or immunity cards. And that way these people could go back to work or could help the elderly, they could help their older relatives. And we do have a curfew in Chile, and we do have a quarantine in most places in Chile. So if we give out these cards, these people could go back to work, etc. So these are called COVID cards. These should also be given to people that have an IgG level that is negative after 21 days of quarantine. We could perhaps give these people these COVID cards, and this would really boost the health workforce because people could go back to work, their children could go back to school, and they could go back to a normal life, in inverted commas. So some countries are calling this an immunity passport. We think that perhaps we shouldn't call it this from a legal point of view, because of course ensuring or guaranteeing immunity is quite legally dangerous, but we would like to have this card, which perhaps we could call a COVID card. So this means that after they have been diagnosed with COVID and after they have recovered and they have a high number of antibodies, that they could go back to normal life. There are lots of people that are so worried about dying from coronavirus, and this has spread terror to our citizens in Chile. And we really think that we need to have an antidote to this. We need to try to calm people down and to make sure that people aren't as afraid. Perhaps with these cards, we could help the population understand that some people have recovered and are able to go back to work. Now, to conclude, I would just like to call on all our colleagues, all the healthcare personnel throughout the world to work very hard on this illness. We know that there are going to be 2, maybe 3 waves of this illness before we find a universal vaccination. Moreover, there might be an immunity level that is reached amongst the population that might be quite high, and that would discourage the pharmaceutical industry from developing a vaccine. But in any case, we are making an appeal to all countries to work on this and to make sure that they work on their border closures. We know that there are a lot of immigrants that want to go back to their countries, and they won't be able to do this because they don't have the right to return. So I think that these are all topics that the WHO, as well as the United Nations, should really pay attention to. We need to have a bit more guidance on all of these border closures and air traffic, international travel. There are thousands of people that want to go back to the countries where they come from. Now, I wouldn't like to take up too much of your time. I would just like to once again express my deep gratitude, deep recognition to Dr. Tedros, to his staff, and to all the workers around the world, all the work that you are carrying out in this situation that is really a historical moment. This is unprecedented for world history, and I'm very pleased that you, Dr. Tedros, are leading this new crusade. Thank you very much for your attention.
Thank you very much, Excellency, for your presentation. As in previous weeks, I plan to run through each of the country presentations before returning for the Secretary to respond, and then opening for questions from other member states to the presenters. I'd now like to invite Honourable Minister of Health and Medical Education from Iran, Dr. Namakay, to take the floor to give your country's presentation. Over to you, sir. Thank you.
Ar-Rahman Ar-Rahim. Distinguished ministers, dear Director General Dr. Tedros, ladies and gentlemen. At the outset, I would like to appreciate Dr. Tedros and WHO headquarters for organizing this important session to share experience to better fight COVID-19 pandemic. Since the beginning of outbreak in Wuhan, I mandated several committees to set up public health measures, laboratory diagnosis procedures, and hospital management. The first case of laboratory confirmed COVID-19 in Iran were on 19th February 2020. The surveillance system immediately scaled up its case detection activities throughout the country. Currently, we have more than 86,000 positive cases and almost 5,400 deaths, while more than 65,000 have been recovered. Community transmission is now controlled through our national campaign and smart physical distancing. The CFR is going down, which may indicate a better care during the time. In our national campaign, more than 71 million people were screened by phone or online, using the strong primary healthcare infrastructure with a stepwise referral system. In this national plan, our frontline health workers screen for mild cases, then referred to designated 24-hourly health centers to have the test for outpatients. 2.4 million people were followed up, 790,000 were visited in our patient center. Among them, just 4.3% referred to hospitals. This stepwise protocol has dramatically reduced the load of our ICUs and hospital admission to the fact that we have free ICU beds across the country. However, we are very vigilant for the second probable peak. The ultimate support by the Supreme Leader, President Rouhani, and the Supreme Council for National Security within the framework of whole government, whole society approach, supported the MOH to benefit from military commodities and all facilities to transform temporary isolation units where post-discharge patients and also suspected cases are admitted to cut viral transmission early isolation, and early treatment. However, because of the impact of the national campaign, we have not used most of the capacity of these units. At the same time, the government of Islamic Republic of Iran has provided a special package for the poor and economic protective measures, particularly for small business. Normal trade between countries should be sustained according to IHR. To do this, we have developed extra environmental health measures at the borders, which needs WHO support for better implementation. Excellencies, as the Minister of Health and Medical Education, I have been fully authorized for all kinds of national plans and orders. Since the beginning of the epidemic, several public health measures such as the closure of schools, universities, mosques, public places were closed. While in the phase of smart distancing, 2.3 million small businesses and shops have been registered in a particular database so that their compliance with health protocols could be measured and reinforced. Several clinical trials and more than 1,000 research projects are undergoing, while startups are strongly supported to produce local needs and even more. Combating COVID-19 pandemic requires global solidarity in action and international cooperation in practice. This is the time for solidarity, not exclusion, as rightly pointed out by UN Secretary General and echoed frequently by Dr. Tedros. We appreciate member states who requested load removal of US sanctions against Iran and other affected countries. We strongly support the leadership and technical support of WHO in this pandemic. I would like to urge international community to consider additional support to the poor countries. We are at the vital chapter of our shared responsibility to respond to this pandemic in a collaborative and collective way. In this context, Islamic Republic of Iran is ready to provide technical assistance to the low-income countries in addition to PPE, disinfectants, ventilators, and other high-quality local products in the next few weeks. The World Bank and international economic organizations should plan even for the post-COVID world. The pandemic affects macroeconomic in the rich countries, while microeconomics and the households are the first victims of economic disadvantage in the poor countries. I would like to commemorate the frontline healthcare workers in combating COVID who dedicate their lives to save the others. Ladies and gentlemen, together we can defeat COVID, inshallah. Thank you very much.
We understand that the minister has signed on with the login name Sibu Ingubani. Sibu, you have the floor, please.
Thank you very much. I would like to first thank the Director General of WHO for inviting us to this very important session. And I want to say we have learned a lot from the experience of many other countries in the world who have dealt with this challenge of COVID-19. As South Africa, led by our President Cyril Ramaphosa, we started by looking at this issue from a point of view that it is a multidisciplinary issue that requires the whole of government to respond to the issues that are arising. As a result, we therefore created what we call a command council, which is a coronavirus command council that is dealing with all the issues that relate to the outbreak. And out of these issues, health is a lead department, but most of the other departments have had a role to play in looking at how they can deal with the challenge of COVID-19. At this point, we had our first patient on the 5th of March, and at this point, our numbers have gone to 3,600. But we had in the process our predictions that indicated that we are likely to get the peak of the pandemic around May, June, July, and therefore we were concerned about the impact it would have in overwhelming our services. And as a result, therefore, we sought to take an approach that would help us to delay the infection and flatten the curve. So we took the approach that we need to combine the work that's being done by the Department of Health together with what the rest of the government has to be doing. And so in the process, we have therefore found ourselves in a situation where the first few cases that arose arose when we had already started preparing our community for the kind of challenge that the country is going to be facing. In that process, we found there was a lot of panic that we had to address. We found that there was a lot of panic that we had to address, and so it was decided that early on we have to take an approach that focuses on, as soon as one patient has been found, contact tracing becomes important, that we move out and try and limit the rate of spread of the infection. And having done so, the next focus, of course, has been the preparedness to be able to manage cases once they reach the hospital. And in our experience, we found that a number of the cases were actually largely initially imported cases, and so it was easy to deal with them because they were very mild or asymptomatic, and they were asked to be isolated at home, and we found that this was quite helpful. And this meant for us that the numbers of the first few of the patients that came through were actually imported cases that were relatively easier to manage, and we used quite a lot of the private sector to be able to treat some of them and also test those particular patients. Over a period, we started getting the community transmissions, which started indicating to us that some action was needed. In this case, the decisions were taken to make restrictions on large meetings, postpone some of the Easter weekend church services, stop large sporting and cultural and music festivals and so on. This assisted quite a lot. As a result, when we looked at the trajectory of the South African outbreak, we noticed that as soon after those restrictions had been put in place, we started seeing a slight change in the trajectory of the epidemic. If you look through, as we compare, it started actually showing a slight change at that level. In this case, what we had actually started was to embark on a whole program of reaching out to the communities, because we needed now to buy additional time to prepare more beds, to prepare more testing capability. And in that process, we rolled out a huge number of community outreach programs where we would send community health workers. At this point, around 57,000 community workers are out in the community, talking to communities, looking for symptoms, and then we getting them tested in the process. So about 2 million people, in fact, close to 3 million now, have actually been screened for symptoms, largely because we have now noticed the fact that the internal transmission is taking place, and that has actually assisted a lot. And so the testing capability has been increased to the level that at this point, if we look at the next graph, it shows, the upper graph shows when there's a hump around the 26th, that's when the first restrictions were put in place. It has actually helped to reduce a little bit in terms of the numbers of patients that we're seeing, but with the increased testing, we're seeing that the numbers are already showing an increase. At this point, we would say that the numbers of people who are testing are close to 1,700 per million population. We need to increase it because we are looking at some of the countries that's been successful in this regard. And also, if you look at the weekly testing, even the government side capacity has been ramped up. So increasing testing capacity has also been very, very helpful. It helps us to be able to identify more people out before they are sick, because our concern is to avoid them overwhelming the situation. So at this, again, if you look at them, the numbers that are hospitalized are slowly increasing, but we're still very early in the curve, and that's why you've got about 256 people who are admitted, but the numbers that we have is about 3,600 at this point, and so we haven't got our system overwhelmed already, but we have got already 1,369 recoveries. So that's already giving us a sense that there's been an impact to delay the curve. If you look at this, our forecast was indicating that if we left without doing anything, the first curve was going to be the rise in the curve. On the extreme right is the probable scenario that we are working towards, where the curve will peak around September. Then during that time, it's going to allow us to increase more testing, to increase, to be able to find the prevalence of the infection in the communities, particularly the poorer communities, the densely populated communities which are serviced by the public sector. And all of this is something that we believe we've been able to gain some time during the lockdown. I think the 3 weeks has been able to help us to shift the curve from the left to the right. And that shifting, the additional 2 weeks has also helped us to improve the numbers of field hospital beds, which we need to create, and also to make sure that we create the awareness. The main issue for us is about changing the social behavior in relation to people understanding the social distancing and the numbers of the use of masks. At this, we're also encouraging that the surgical masks, we also have run short of the supplies in the country. Those must be kept for the professionals, because we have to protect our staff. And at the same time, we're encouraging the use of cloth masks where communities can make them for themselves, so that there is no need for the meager resources to be spent on the communities. So we believe, therefore, that there has to be a staggered approach to looking at the return to normality. We're using, again, the same focus to look at the numbers of beds that are going to be needed in the next few months. And we're looking at the best case scenario, worst case scenario, and therefore all of this is part of our focus. At the end of the day, our focus is that we need a risk-adjusted return to normality. And here we want to be able to grade every region, every district, every ward on the basis of the risk level that we can see. The level 5 is where we've got currently, lockdown, no movement, and at the same time, high level of viral spread, and we're moving upwards to the levels where there will be low risk. So we'll open up activities on the basis of where there's lowest risk, and therefore slowly we're going to try and get back to normality. The real challenge is here at the supply of protective clothing. We will be participating in the therapeutic and vaccine trials. We therefore want to make sure that we are in line with all of the work that's being done globally. And we're also looking at how to manage particularly the reopening of borders and all of those issues and opening of industries, trying to balance the risk of the spread of the infection with the economic activities. Some of the challenges already indicating coming through are that of this loss of income. So the president has announced now packages to support small businesses, the communities that are indigent, and also to support major industries to be able to begin the process of reconstruction so that we can return the economy to normality. We believe we are going to be, with this COVID-19 for a while, and therefore a lot of work has to be done to, cooperate with the rest of the global partners in this regard to get therapeutic agents and to also get vaccine to be able to get to deal with this issue. We want to thank WHO for all the technical support that they've given us. We've also got support from other partners, from China, from Cuba, from PEPFAR and Global Fund, the US government, and all the other partners who have worked with us, because some of the resources that we've put on the ground to increase the numbers of people who are being tested and as well as tracing of the contacts are coming from programs that are funded through civil societies by various players. So the maximum response that has come into this has come from literally all the players that we're working with and all the partners. We believe that it's giving us some benefit, but of course we stand to learn from many of the countries for the work that is being done. We want to thank you all for the kind of readiness to give us support whenever we call in. And we want to say to you that moving forward, we really want to be in line with all the current advances, both in terms of the research work that's being done, as well as some of the lessons that are coming through from the different parts of the world. Thank you very much.
Thank you very much, Minister. Ms. Hallegren, you have the floor. Thank you.
Thank you. Dear Director General, Excellencies, my name is Lena Hallengren and I am Minister for Health and Social Affairs in Sweden. Today I'm here with Johan Carlsson, Director General of the Public Health Agency in Sweden, and Olivia Wikstell, Director General of the National Board of Health and Welfare. Thank you for the opportunity to brief you on Sweden's approach to combat COVID-19, and thank you, WHO, for all the work and support to help us all to fight COVID-19. There has been some interest internationally in our approach to combat the virus. Despite this, I would say that there is no unique Swedish way of dealing with the coronavirus. We do what we think is best, based on the development of the pandemic in Sweden and our national circumstances. We are very practical and open to implement any measures that we think would be effective. But in order to understand our approach, it helps to be aware of some fundamental characteristics of the Swedish society. Our welfare state is universal, including the healthcare system. It is publicly funded and accessible to all. In addressing this situation, we try to build on and utilize established national institutions. There is a tradition of mutual trust between public authorities and citizens. People trust and follow the recommendations of the authorities to a large extent. The Swedish government has, from the start of the outbreak, applied a whole of government approach. We have presented a range of different measures, both voluntary and legally binding, to limit the spread of COVID-19. Our measures aim to save lives and slow down the outbreak. We've carried out a number of reforms to strengthen our healthcare system so that our doctors and nurses can cope with the extraordinary challenge that COVID-19 poses. In my presentation, I'd like to highlight 5 aspects of our approach to the coronavirus. First, the government has the overall responsibility, but Sweden's public health response is largely based on advice from our expert agencies. Early in this progress, the government decided to let decision-making be guided by available knowledge and evidence on effectiveness. The responsible national agencies, as well as international organizations and authorities, such as the WHO, therefore has an important role in our response. Second, protecting the elderly and people in other risk groups is a top priority. The government has banned visits to care homes for elderly where the most vulnerable live. We have also issued strict recommendations for people over the age 70 to avoid physical contact with others. The whole population is recommended to refrain from visiting elderly. Sweden faces the same challenge as other countries in keeping the elderly safe and protected, especially in vulnerable settings such as care homes. High numbers of infected people at homes for elderly care is one of our major concerns. Third, social distancing and incentives to stay at home are key tools in our strategy. The government has banned public gatherings of more than 50 people. We have also implemented distance and online education for upper secondary schools and higher education. It's easy for people to stay at home when sick. However, we have carried out some additional changes to strengthen the incentives for people to stay at home from work when they show even the slightest symptoms. Employees and self-employed will get paid sick leave already from day one, and we have waived the need for a doctor's certificate. A new legislation now authorizes the government to rapidly impose even stricter prohibitions on different kinds of public gatherings if deemed necessary. It can also force actors to redistribute medicines according to needs. Fourth, we aim for strategies that last over time and public trust. Sweden's efforts consist of a combination of legislative action, strong recommendation and guidelines, awareness raising, and voluntary measures. Measures need to last over time and be acceptable to the public. Also, we're trying to implement the right measures at the right time. Distance education and working from home has significantly reduced movement in society. So far, it has not been necessary to implement a total lockdown of the whole Swedish society or implement confinement measures. Our assessment at this point is that people mostly follow recommendations issued by the government and the responsible authorities. This makes us convinced that strong legal measures are not the only way to achieve behavioral change. That being said, we monitor the situation closely and are prepared to implement stricter measures whenever necessary. This brings me to the fifth aspect of our work: flexible adjustment to developments on the ground. We continuously assess the effectiveness of our interventions and let the epidemiological developments guide how we combat COVID-19. One example is the new legislation I previously mentioned. Another is the decision to increase the testing capacity. We recently adopted a national strategy to ensure that the number of tests increase. Since the beginning of the outbreak, we have also more than doubled our intensive care capacity and reallocated resources to expand the number of beds available. At present, we have an excess intensive care capacity of around 20% at national level, even if it's under high pressure. It's far too early to draw any firm conclusions on the effectiveness of the measures taken in Sweden. But so far, the care needs in Sweden are met. We monitor the intensive care unit's capacity on a daily basis in order to have a good overview and be able to nationally coordinate the intensive care unit beds according to needs. Since the beginning of the outbreak, the geographical spread of COVID-19 has been most frequent in the Stockholm area, where most cases of illness have been confirmed so far. Right now, it's important that everyone keeps adhering to all recommendations in order to keep numbers down. I want to emphasize the need for international cooperation and solidarity between countries. I would like to express Sweden's strong support and appreciation for WHO and the important job this organization is doing. As one of the largest donors of unearmarked core funding, I'm happy to see that our funding has allowed organizations to act flexibly and quickly when needed. There is no denying that this pandemic is a tragedy affecting all countries and levels of society. But we can see some other side effects too. Temporarily laid off employees from different sectors are being rapidly trained in basic healthcare to join the health workforce. Companies have changed their production and started to manufacture personal protective equipment. And since the outbreak started, there has been a major increase in the number of applications to medical educations in Sweden, and I'm very glad for this positive development. I'd like to conclude by reiterating the main message for this briefing. There is no unique Swedish way of dealing with COVID-19. We share the same goals as other countries. We work with the same challenges as other countries, and we use similar tools as other countries. We do what we think work best for Sweden in our natural circumstances, and we're always prepared to implement stricter measures if necessary. Lastly, I'd like to thank WHO for the opportunity to present Sweden's response to COVID-19. Thank you.
Thank you very much, Minister Hallengren. It's now my pleasure to give the floor to His Excellency, Dr. Vardhan. Dr. Vardhan is the Union Minister for Health and Family Welfare, Science and Technology.
Thank you, Dr. Tedros, all the other distinguished officials in WHO headquarters and my regional office, all my dear colleague ministers from all parts of the world, of course all the 6 regions. First of all, let me thank WHO, my regional office, for giving India this opportunity of presenting on behalf of the regional office. I am extremely grateful to all of you. So I start with my first slide. This slide depicts that India responded to this challenge within 24 hours of getting this news from China that they have detected this new coronavirus on 7th of January. On 8th January itself, we had organized our first meeting of the expert group of technical people, our doctors, epidemiologists, and whosoever was relevant. Within the next 7 days or so, we had formulated our detailed preparedness plan, which we had sent to all the states in the country. We also started our community surveillance on the 17th of January itself, although our first case came 13 days later on 30th of January. And we had also started screening flights coming from nations where the infection had been reported. And this slide also shows that at only about 600 cases we implemented the nationwide lockdown first till 14th of April and then have extended it till the 3rd of May. We in fact adopted the preemptive and proactive and a graded response. You can see in the slide that we also implemented the Janta curfew. It was like a mock exercise done voluntarily by the people on 22nd of March. This is a slide which shows that post 5,000 cases, India reported less than half cases as compared to Italy, China, Spain and France. At the end of 14th day, India reported 1/10 of the cases that USA had, and India's doubling rate is less than 2 times that of USA. This is a slide which shows that right from the day one, our Honorable Prime Minister has been monitoring the progress of the various developments. He has been in continuous engagement with the Chief Minister, the He constituted a group of ministers under me with all the relevant ministers there. We already had 13 meetings of this group till now. The Health Ministry has been reviewing everything regularly, sending regularly advisories. There is a committee of secretaries. There is a regular interaction with the states, their health ministers, their health secretaries. 11 empowered groups of the top officials of the Government of India in the whole government. They have been formed to look after various issues. There is a national task force of eminent medical and public health experts, and regularly we have been sending senior officials to the states to ensure that there is a continuous link with the states. This is a slide which shows that we in fact had strategic interventions for virtually everything right from the beginning, whether it was screening at the airports, whether it was screening at the ship ports, whether it was screening at our borders with our neighboring country like Nepal. And then we had activated our very powerful and robust integrated disease surveillance network right from 17th of January. We started working on the logistics about the personal protective kits, N95 masks and diagnostic reagents. Also, we started from the day one. You will be happy to know that we had just one lab when we started this in the first week of January, and in the later slide we'll show how much we have in fact scaled up and improved our capacity of lab testing in this country. Then simultaneously we started about hospital preparedness, isolation beds, critical care beds and ventilators and things like that, and also the risk communication strategy to connect with 1.35 billion people in this country. And then the capacity building. We trained I think over 1 million people over the course of the last 2 months, starting from the grassroots ASHA workers to the topmost people, not only in the health department but in all other departments also, which were all, it was a total government approach which was adopted. People working in immigration, people working at airports, people working in defense facilities, people working in virtually every sector of the government, they were all trained to handle COVID during the course of the last few weeks. Yes, this is this is just telling you that we screened at all our 30 international airports till 23rd March, and we screened 15.25 lakh passengers. And at the airports there was a thermal screening, there was health risk profiling, and then quarantining the passengers as per the protocols. And every information at these airports was shared with the states all over the country for community level screening. Then similarly, as I had mentioned earlier, you can see here that we also screened passengers at 12 major ports and 65 non-major ports in the country. Isolation wards were set up at the major ports, cruise ships were prohibited, and we screened 1,062 vessels and 49,000 passengers were screened. Similarly, at the land borders, when we had the first case in the neighboring Nepal, we started screening there, and we screened 20.70 lakh people, and also we organized Gram Sabhas in the adjoining 5,000 villages. This is a slide which shows that in spite of all these difficulties, we were able to bring back 2,544 of our Indians and some foreigners also, some 49 of them from Wuhan, China, and from Japan, Iran and Italy during that crisis in the initial stages. This is the slide which tells us that while the borders were being secured, community surveillance was ramped up to find any case within the country. We did a rigorous contact tracing. It was initiated so that not a single case is missed. And more than 9.42 lakh passengers were brought under surveillance. 70,000 people found symptomatic were referred, 14,000 were hospitalized, And the next slide will show you you see, this is a snapshot of the rigorous methodology that is being followed for contact tracing. This is the description about the third case in India. This is a 23-year male student who had come from Wuhan, Hubei. This individual traveled from China through 3 cities, stayed in 2 hotels and took multiple taxis and other public transport to reach his home. He was traced through all the journey and all the 162 of his contacts were successfully taken under the surveillance radar. This is the chart of his journey from China to his native place, his home. This slide shows that how from one lab in the country in the first week of January, we have now expanded our laboratory network. We have a capacity of doing 55,000 tests per day. We want to expand it to 1 lakh tests per day by the 31st of May. You can see that in the last 4-5 days we have been testing over 30,000 people per day. Until now we have tested around 5 lakh people. There is a very judicious testing principle and there is an efficient response. On the left you can see that what are the criteria, well-defined criteria developed by the experts, and also we have now started doing rapid antibody test for all the ILI patients in the containment zones. This slide shows that from one laboratory we have expanded our network in the country to 230 laboratories in the government sector and 87 laboratories in the private sector, with 16,000 collection centers all over the country. And by the end of this month, we want to expand this laboratory network to 300 labs in the government sector only. This is, you can see that all over the country now, within the short span of these 2 months, we have developed laboratories in the remotest part of the country. This is a slide which tells you that we had this hospital preparedness as one of our focus areas for preparation of a high case load. If this happens, we have emphasized on creation of dedicated COVID hospitals so that other patients do not intermingle with COVID patients, non-COVID patients. Since this is a highly contagious disease, we have ensured that there are 3 types of dedicated hospitals, and they have been created on clinical condition of the patient. On the basis of clinical condition, they are the COVID care centers for mild symptomatic cases. They are the COVID health centers for moderate symptomatic patients, and also the COVID hospitals for severe patients. And there are ambulances which have been made available for transport of patients between the various centers. This is the slide which shows that although we do not anticipate that we will have the worst of conditions, but still, God forbid, if we have them, we are prepared for the worst also. And all over the country we have already in advance created these dedicated COVID hospitals, these dedicated COVID health centers, total functional COVID dedicated facilities. This is a slide which gives you the description and also the number of facilities and the number of isolation beds and the number of ICU beds and the number of ventilators which are already reserved. But over and above this, we have already ordered for around 55,000 more ventilators. So we are well prepared to handle any unfortunate eventuality in the country if it unfortunately happens. Then this is a slide which tells us that right from the day one we have been keeping everyone in the loop. All our 135 billion people, there is a press briefing every day at 4 o'clock. There is a risk communication material has been distributed to every Indian through all possible means, print, electronic, social media, ISE material through all regional languages in the country, 5.5 billion text messages about do's and don'ts sent to every Indian, caller tune message to 11.7 billion telecom subscribers in 13 languages, telling every Indian in the remotest part of the country about what are the do's and don'ts, 24/7 national control room from the very beginning, and also a helpline and also state call centers all over the country. This is again a slide which tells us about how we have been using the social media, also the MyGov platform and the other possible. Recently, we have with the help of Twitter started a COVID-19 Seva also, and all possible mechanisms we are using to keep the people of India informed about what is actually necessary for them to do. This slide is, I had spoken about this capacity building. So we started this very early. You can say, you can see here that on 6th of March we had a very huge national level training of trainers, which was connected at more than 1,000 places all over the country, and lakhs of people were trained in that. Then we followed it up with training at the state level, the district level, the hospital level. There had been a web-based training for ventilator management organized by one of our premier institutions. On 22nd March, there was a mock drill for corona preparedness in all the hospitals all across the country. Series of training workshops by AIIMS New Delhi for the doctors in the private sector, for Indian Medical Association, for designated hospitals, and then I got platform for anytime, anywhere and across all channels, resources, material for online training. This is the current status. You see, right now we are confident about what is happening in India because we know where our enemy is. And right now we have divided the whole country into either there are the more than 50% of the districts in the country are non-infected districts where the infection hasn't gone there. Then there are the hot spots which we have said they are in the red zone. And then there are the non-hotspot districts where there are only about 1, 2, 3 cases, very minimal number. And then you can see here there is a strategy for the red zones also, hotspot districts with large outbreaks, hotspot districts with clusters, and then in the non-hotspot districts with clusters. So there is a criteria. If a red zone district remains without a new case, no case is reported in 14 days, we convert that, we call that, shift that district into an orange zone. And if further 14 days there is no case, then we shift that into a green zone. So there is a well-defined strategy. This slide talks about the strategy, what is the strategy for the large outbreak, and where we say there's more than 15 cases in that district. Then the strategy for the cluster management, where there are less than 15 cases in a limited area. Then, of course, next is about discrete cluster containment plans have been designated and deployed for both cluster containment and large outbreak containment. We are also sharing the best practices between districts so that people can learn from each other's experience all over the country. There is a focus on over-preparedness at the district level, and this is being promoted. And there is continuous focus on surveillance, contact tracing, and patient management. Here you can see that there is a there is a cutting-edge technology which is being leveraged to streamline operations at all levels of COVID management. On the extreme left, you see the Arogya Setu app. This is being used by millions of citizens to assess the risk of COVID infection in their area. It has been downloaded right now by 72.19 million people. Times as of now by 70.46 million users. And similarly, you can see on the right side, digital tools are also there for estimation of health infrastructure from caseloads, and they have been developed and also shared with states and districts to inform about their infrastructure preparedness. This is a slide which gives you an overall update about the total number of cases, the deaths. Our mortality is about 3.2%. The global one is 6.9%. Right now, the doubling rate over the last 14 days is 8.7 days, and already 4,258 patients have gone back after having recovered. And this map shows the red zones or the hotspots and the orange zones or the non-hotspot districts, and of course the green shows the non-infected districts in the country till now. As you had also mentioned that apart from being the health minister, I am also the science and technology minister and also the minister for earth sciences. So this is a brief description of our Science Ministry is also very, very proactively working on the various aspects related to development of, vaccine, discovery of drugs, development of new technologies. We are relying on science to tide over the current crisis, and thus ongoing research is also a very top priority of the government. India is one of the 5 countries globally to have isolated the virus. Our institutions like ICMR, DST, DBT, CSIR are not only conducting individual research, but are also collaborating with the academia, startups, and the private sector to develop various COVID-19 solutions. This is an excellent example of the whole of the government and whole of the society approach. Then this is a slide which mentions that it is not only the scientific and the health inputs, but on the economic front and on the human front, the Prime Minister has launched a big package, economic package, and through various schemes, whether it is providing food or money into the bank accounts of the poor people, giving free gas cylinders, or helping the farmers, helping the poor women, helping the poor laborer. It's about also you can see all health workers all over the country who are delivering a UMN service to the community. They have all been insured for an amount of 50 lakh of rupees. It's about 22.12 lakh beneficiaries. So this slide shows that the government of India has also ensured benefit packages for the vulnerables and the poorest of the poor during these challenging times. And more than 17,500 crores have been allocated as a stimulus package. Then this slide shows the current focus areas, which include active surveillance, robust hospital preparedness, and capacity building of our healthcare workforce. Then again, the next slide, it shows rigorous cluster containment, which needs to be implemented for breaking the chain of transmission. The senior state officials, they have the supervisory role. The DMs of the country, they are continuously being talked over by the health department, by the cabinet secretary, and the highest level is coordinating with all the other departments in the government and all the chief secretaries of all the states. And all this is happening very, very proactively, continuously. Rapid response teams all over the country, our surveillance officers at the district level, and demarcation of containment and buffer zones, house-to-house surveillance of within a diameter of 5 kilometers, where we have all these hotspots and big outbreak containment strategies. So this is all happening very actively. This is the now this is finally, you see, we have been propagating to the people of India that till the time we are able to find a vaccine which is going to help only a single individual, we have been telling the people that social distancing as a change in your behavior, this is the most potent social vaccine which is available to us and of course to the whole world. So Prime Minister has been talking about social distancing every day. We have been requesting people to in fact respect and honor the guidelines of the lockdown also. And we are quite hopeful that we have total control over the situation, and we know where the enemy is, and we know the strategies that we have to adopt. We are carefully and committedly, in fact, implementing those strategies and watching them with meticulous precision about the faults, and sending teams from the center also, taking feedbacks, doing regular video conferencing with our health ministers all over the country, with our chief ministers all over the country, with all our officers all over the country. And since it is a WHO forum, we had a video conferencing with where people at 1,600 places all over the country, our WHO surveillance officers and also our WHO monitors in the field, they are also engaged in the whole activity, helping our regular surveillance officers and our rapid response teams. I am sure that the way WHO is helping us to coordinate with the rest of the world and making us aware of the experience of the rest of the world, I am hopeful that very soon the whole world should be, I think we should be able to win the war over COVID. And not only praying for my own Indians, but for the people all across the world. I once again thank you and pray to God for the health of every person on the globe. Thank you, WHO. Thank you, Dr. Tedros.
Thank you very
Your Excellencies and Honorable Ministers. I'd like to share with you slides of the work that we've been doing in Fiji in relation to COVID-19. And also some of the challenges that we have been facing. Slide. Tosara. We had a measles outbreak in November, and this has been overlapping to the beginning of this year with COVID-19. Within 6 weeks, we were able to vaccinate 500,000 Fijians, even though we knew that we had herd immunity. We were worried about the challenges within the Pacific and in the region. We had 28 cases of measles and we had no deaths. And towards the end of the measles outbreak, we started with COVID-19. Despite that, we still had the challenges of tropical cyclones. We were hit by 3 tropical cyclones. The first 2 were category 2 and 3. And the last one, which is just left, was a category 5. That went through the lower part of the nation and did considerable damage in some of the islands on the lower part of the group. There was extensive work that needed to be done throughout the cyclone and post-cyclone, where the Minister of Health was involved. But certainly from our point of view, that work was in addition to the COVID-19 work that also needed to be done. So we had our normative functions of the Ministry of Health and the extra normative functions with the cyclones and COVID-19. Here before you is a slide that shows the cases that we've had in Fiji. Our first case was in 18th of March of this year, and we've had 18 cases, and we've had 8 recoveries. At the moment, we have only 10 active cases. We've done considerable contact tracing for a population of 850,000. We have used our hotel facilities, as we all are aware, that currently at the moment with the drop in airline travels around the world, our tourism industry is essentially lying dormant. So we're using the hotels that are available to be able to use as quarantine centers for those who are coming from overseas. We've also embarked on a massive fever screening exercise. We're using mobile and also fixed fever screening clinics. And so far we've seen more than 40% of the population using this. and this has also generated some for testing. And so far, we haven't got anybody from the extensive fever screening that was tested to be positive. All the positive cases were all clusters of the 6 imported cases, and all within the 18 that we have at the moment. We have a whole of government approach, just like many other countries listening. Plan the extensive tracing which we are using other companies like the discipline forces to be able to support us in using software that we've been able to purchase and also make a look for those who will be able to support us with making apps. The massive fever screening is probably the biggest public health exercise that we've ever done in this nation. We've had school closure and targeted community lockdowns, initially in the other city, and then as of recent in the capital city in which I'm talking from, and also certain communities in which there were high risk of about 30 to 50 households that we've locked down. We are currently on curfew, and as I speak, it's very early in the morning here in Fiji, and there's a curfew outside, and closure of all non-essential areas that might be petri dishes for the spread of COVID-19. We've also had a very significant partner in donor coordination and support coming through our development partners. We've also used the border restrictions, the bans on flights and cruise ships, border screening, hospital isolation facility. We've also identified community surge planning bed isolation facilities. As a government, we took to Parliament a supplementary budget specifically for COVID-19 to support the work of the Ministry of Health, but also the other ministries. As you're all aware that with COVID-19, the economy around the world is all taken a big hit, including small island development states such as Fiji. 32% of our GDP is dependent on the tourism sector. So it was important to be able to mobilize resources to provide social protection for those who may be affected. The next slide shows the work that has been done leading up to the first case on the 18th of March and all the other work that's been going throughout in the strategies up until today. You will see that since January, we've been talking about COVID-19 and done things such as the introduction of the supplementary arrival cards, the closures of border to foreign nationals of certain countries in which it was quite significant, the spread, the drafting of our preparedness and response plans, the stopping of cruise ships, and then when we had our first case, that's when we started closing schools and did limited lockdowns in certain areas. This is carried on, and also the work around the tropical cyclone that we've had, including the use of quarantine facilities. And I think that slide in itself is very informative in terms of the intervention. So they act as triggers to what our response will be. For Fiji's situation, we have 3 levels. And before we had our first case, we were already in level 1. And when we had our first case, our actions were level 2. So at the moment, we are still in level 1 in terms of the cases and the cluster. But the actions that the Fijian government has taken is the actions that are in our level 2. And that, I believe, has led to us flattening the curve, so as to speak, at the moment. This is a slide to show the 6 important cases and the cluster links. The green denotes those that are now well and have recovered after testing negative on 2 to 3 occasions. And they are as above on cluster 1 and also in cluster 4. And we are hopeful that in the next few weeks, all those red will become green. And we're also very hopeful that none will pass away from COVID-19 and that they will all. So at the moment, as we speak, we have a 44% of our cases have recovered. The testing rate is 1 per 1,000, which is equivalent to many other nations that are developing or developed nations around the world. And as I've alluded to, the recovery rate is 44%. We've had an amendment to the Public Health Act specifically for COVID-19, and this was done as one of the consequential bills when the supplementary bill for COVID-19 was passed in the national budget about 2 weeks ago. We've also had the declaration of COVID-19 as a natural disaster, and this also with the declaration of the tropical cyclone as a natural disaster. So at the moment in Fiji, there are 2 states of natural disaster, being the cyclones that have passed through and also COVID-19 as a natural disaster. And by doing this, we are mobilizing all resources of government to support the work around COVID-19, but also the climate-sensitive diseases that happens after the natural disasters, such as leptospirosis, typhoid, dengue, and diarrheal diseases, to name a few. We've also had multi-agency engagements and buy-in into the work that we are doing. This is important because Fiji is a hub for the region in the Pacific. Our airline connects many of the small island states within the Pacific, and more importantly, we're a hub for education and businesses. So it was so important that we get on top of this COVID-19 and the response that needs to be done for the cyclone so that we can carry on with business as normal. The way forward for Fiji is what we've done is we've developed a workplace guide that's been given to the Ministry of Employment, and this is the new normal. We have to accept the new normal is different. It's obviously a boost for the work that we've been doing at the Ministry of Health in trying to bring about a healthy population in Fiji, and we are grateful that the Minister of Employment and all the other and the business and partners have taken it on board. We are making a call to WHO and partners to support Fiji and small island development states in combating climate change and climate-sensitive diseases. And we call on WHO to facilitate a fair distribution of technical support and assistance for COVID-19 response for Fiji and also small island development states. We also call on WHO and development partners to pursue the development of a vaccine for COVID-19. I thank you.
Thank you very much again, Minister, and thank you again for being online in the very early hours of the morning there in Fiji. Colleagues, Excellencies, ladies and gentlemen, thank you for those presentations. I now intend to open the floor for member states to ask questions. I would like to give priority to those member states who have questions for one or more of the 6 presentations you have just heard. If you do have questions, please follow the usual protocol of raising your hand in the Zoom function, and my colleague Jude Asai, as every week, will assist in the moderation of those incoming requests to take the floor. I will ask again that questions be short, succinct, to get through as many as we can, and it would be helpful if you could please identify to which country or countries you are making the request for the question to. Jude, if I could then pass to you to help us moderate this next component. Thank you, Jude.
Thank you very much, Chair, and to our excellent ministers for their presentations. We do have a number of member states who've asked for the floor. I'll go through the first 5 that I have in front of me. I do have a question from Indonesia, from Bhutan, from the US, the Gambia, and Algeria. These are the first 5, but of course there are a number of other countries as well. So I'll proceed to give the floor to Indonesia, followed by Bhutan, and then the US. Indonesia, you have the floor.
Thank you. Thank you very much. Your Excellency, Director General of the WHO, Excellency, Ministers, distinguished participants, ladies and gentlemen. First of all, on behalf of the Government of Indonesia, I would like to express our sincere gratitude to the WHO for their continuous support to the government of Indonesia and the member states of WHO in combating the COVID-19 pandemic. We also appreciate WHO's initiative for organizing this information session on COVID-19. Mr. Chairman, allow me to present a brief update on COVID-19 situation in Indonesia. As of 23rd April 2020 afternoon, Indonesia has 7,775 confirmed cases. For the past few days, the number of patients recovered from COVID-19 has been increasing up to 960. However, number of patients died of COVID-19 remain high, close to 647. The President of Indonesia declared COVID-19 as a national disaster and established a task force to accelerate all measures of prevention, detection, and response to fight COVID-19 in all aspects, including strengthening of coordination between national and local government. The government of Indonesia currently imposes a large-scale social distancing to stop further spread of COVID-19 by imposing measures of a large scale of social distancing. We also have a set of protocol on restriction of the movement of people as we are anticipating series of mass movement for upcoming celebration of Islamic holiday. Indonesia joins the WHO Solidarity Research Trial. We also would like to express our interest to join the effort of developing and manufacturing new medicine and vaccine for the COVID-19 vaccines. As the chair of Asian Health Sector Cooperation for 2020-2021, Indonesia conducted collaboration and has organized Asian Health Ministers special meeting in an Asian +3 Health Ministers special meeting on COVID-19 that discuss regional efforts in the combating COVID-19. Excellencies, there are several key issues that require more effort to be fulfilled in order to strengthen response to fight COVID-19, especially on supply chain for essential medical logistic and invention of antiviral and vaccine for COVID-19. In this regard, I would like to ask the WHO on how is the current development of new medicine and vaccine inventions, and what WHO policy to ensure availability and accessibility of vital medical supplies. Currently, we need more personal protective equipment, reagents, and equipment for treatment. Finally, we realized that we could not stand alone to fight COVID-19. We should work hand in hand, and we are confident that through work together, we will end COVID-19. And thank you.
Thank you very much, Indonesia. I recognize Bhutan. You have the floor.
Thank you, Chair, for the time. We would like to thank Dr. Tedros for your leadership.
There's a bit of feedback. If you could reduce your volume a bit, and please proceed. Thank you.
Yeah, I think this one.
That one's better?
Yes.
Thank you, Chair, for the opportunity to present our interventions. We would like to take a moment to thank Dr. Tedros and the WHO team in Geneva for your leadership and continuously guiding the member states in this pandemic. With that, we would like to really request the countries that have shared their experience in terms of use of rapid test kits in screening and also for the use of RT-PCR for confirmation. If you can share some country experience for the use of RDT. With that, again, as a nation, we would also once again like to highlight the need for the humanitarian corridors so that as a global citizen, we can come together and address the urgent need of PPEs to protect our health workers in the front line. And similarly, being a landlocked country, we are also experiencing a huge shortage of medical equipment and supplies. In that regard, we would really like to advocate and encourage member states to have stockpilings, be that in the region or in one specific country. So I think we would really appreciate if the countries that have presented their country experience, if they could also share their experience on the use of RDTs. I think that's it. Thank you very much.
Thank you very much. We will proceed to US and then the Gambia. US, you have the floor, please.
Thank you, Chair. The United States appreciates the presentation from each of the speakers and WHO for convening this meeting. With regard to the presentation by the government of Chile, we would appreciate learning more about WHO's assessment of recent serological studies. Has a determination been made about what tests are sensitive enough to conduct community surveillance, especially as countries consider restarting their economies? What is WHO's opinion about the use of serological tests to identify individuals with antibody response and potential immunity? And to provide a point of clarification, the United States has and continues to offer humanitarian assistance to the Iranian people to help address the coronavirus outbreak. Our priority has been to stand with the Iranian people, and this offer is still on the table. The United States maintains broad authorizations that allow for the sale of food, agricultural commodities, medicine, and medical devices by U.S. persons or from the United States to Iran, and similar exceptions apply for foreign persons providing aid. Our sanctions should not be an obstacle to providing aid to Iran. Thank you.
Thank you very much, US. May I now invite the Gambia, followed by Algeria. The Gambia, you have the floor.
Thank you very much. Can you hear me?
Yes, we can. Please proceed.
Great, thank you. The Gambia would like to thank all the presenters for excellent presentations, which actually go to show that there's diversity in how we manage this crisis. I think that's key. I was impressed with the Swedish presentation from that perspective, them being the odd one out really in many cases, and that's meant in a positive way. And it shows that when we set our minds to doing something from an international perspective, we can get various answers that inform us all. And I think the information we will have at the end of this presentation, particularly with a high-level audience and in the likes of ministers of health available, will help us adjust as we go along, because we will improve as we go along our interventions and take the last bit of India's presentation seriously, which is there is no vaccine, and the only vaccine we have is social distancing. And that is a message that has got to be sent clearly to everyone listening to these presentations, but also, most importantly, for the countries where we've seen signs of a relief on lockdown, just to remind them that in as much as they're entitled to diversity in approach, it's important that we have uniformity on the facts. So this is the key message that I'd like to send. I'd like to also briefly just update everyone. The Gambia is a very small country of 2.3 million, estimated in 7 divisions. And right now we only have 10 COVID-19 cases, but we're being vigilant as well. We are in some form of partial lockdown, and lockdowns being very difficult in certain African countries, given the informal sector dominance of the economy, which can't really be put on a permanent hold. But we are taking prudent measures to ensure that things are being done. And let me also offer the apologies of my Ministry of Health for not being present due to, of course, their pressing engagements on the ground. Thank you very much.
Thank you very much, the Gambia. I would like to invite Algeria to take the floor. Algeria, you have the floor. Malaysia, you have the floor.
Very much, Excellencies, Minister, ladies and gentlemen. I'm from Malaysia. I would like to express my grateful meeting for today and listen to 6 countries. As Malaysia's experience COVID-19, we have to notify that our possibility of setting up a network of experts for public health emergency, which we need for future need and strengthening the capacity of existing emergency response network. So for the public health emergency response, we would like to inquire about the possibility of set up a proper protocol, and so as to standardize the data sharing and information regarding pandemic response. And COVID-19 really changed the world behavior, such as now in Malaysia, we really abide to the rule of lockdown, stay home, and social distancing and personal hygiene. This really gives us a wonderful attitude to practice, and such as Sweden, the citizen really abide to the this protocol, so as no lockdowns proposed. So, Excellency, other thing that I want to ask is about a long-term controlling COVID-19. We can't forcefully keep our nation under restricted movement for much longer, such as economic and livelihood are affected, and we wish to inquire on WHO sustainability plan in controlling COVID-19. I wish to all our Muslim friends, Ramadan Mubarak, and we are sure in the fasting month tomorrow. Thank you.
Thank you very much, Malaysia. Algeria, I see you already. I'll give you the floor, and then I would revert to the chair to provide answers to the questions and interventions that have been made. Algeria, you have the floor.
Dear Director General of the WHO, ladies and gentlemen, dear ministers, we would thank you very much for allowing all the member states to take the floor. And we would just have a question on screening. In Algeria, the response to coronavirus has followed the recommendation to the WHO. We have 3 pillars. 1, prevention. And we have a community-based approach. We have been trying to understand the level of the risk, and we have protective measures in place. The interpreter apologizes, but the sound is really bad. It's hard to understand what he's saying. He's speaking about screening. We are also centralizing our efforts. We have been able to deploy our efforts to all regions of the country. Regarding isolation, we have a lockdown in place which is adapted to each local situation. In Algeria, we haven't had many problems in terms of resources and in terms of hospitals that are available and follow-up. However, we have had some problems in our screening strategy. The interpreter apologizes. The sound is very bad. My question is the following. What can the WHO do to allow countries from the African region to have enough of these PCR tests available for us to be able to test as many cases as possible? Secondly, what is the position of the WHO regarding rapid test and has it evolved?
Thank you, Nigeria, and apologies for the lack of quality sound coming from there, and obviously the challenges for the interpreters. But I think the two questions have been well noted. I will yield the floor to the chair and then come back for the next round of questions. Thank you.
Thank you, Jude, and thank you to those countries for those direct questions. I recognize that Bhutan had some questions directly to the presenting countries on rapid test kits, and Algeria, you also had a question in relationship to RTKs. However, I have to inform that Drs. Mike Ryan and Maria van der Kerk have to leave for another meeting, van der Kove, sorry. And I'd like to just give the opportunity to Maria to respond to a couple of specific questions from, firstly, Chile and also on the US on the issues around the serology and immunity. And then we can allow you to get on to your next very important meetings, Maria. So if I could have the indulgence of the participant member states to give the floor to Maria. Thank you.
So thank you, Tim. Thank you very much for these excellent presentations by all of the member states and for these questions. So I'm going to address the issue around the serologic tests first, which came up a couple of times. First of all, we welcome the rapid development of serologic assays for COVID-19. It's been an incredible acceleration in the development of both molecular tests and serologic tests. In terms of the availability of serologic assays, there are hundreds of serologic assays that are now available, which on the one hand is very positive, but on the other, we need to ensure that these tests are validated against well-characterized sera so that they measure what they attempt to measure, and we can quantify that and validate that. We are working together with our collaborating laboratories across the globe who have specific expertise in coronaviruses, as well as FIND, to evaluate, to conduct independent evaluations of these immunoassays, which include ELISAs, which include machine-based or lateral flow tests, rapid tests, which are specific for SARS-CoV-2 antigen or antibodies. This is something that is underway. And we are getting information about the validation of these tests. It's starting to come in now, but it will take some time. We recommend the use of these serologic assays in the context of research at the present time, not for diagnostic purposes. And the reason for that is it takes individuals who have been infected with COVID-19 a week or two to develop antibodies, which is what these tests measure. So these tests are not for acute diagnostic purposes, but we do recommend them for the use of serologic serologic studies. And a number of those studies are currently underway in at least 40 countries across the globe. We are working directly with a number of countries to carry out these evaluations in these seroepi studies, as well as tracking countries who are conducting them themselves and trying to keep track of which results are coming out when. We will be issuing a scientific brief, hopefully today, on the use of these rapid serologic assays and the idea that they could potentially be used for an immunity passport or a COVID card or something to that effect, which we understand that some governments would like to issue for people who have been infected to measure that they are immune to reinfection. Unfortunately, at the present time, we have no data on whether these serologic assays measure immunity. What they measure are antibody response, and a number of research needs to be carried out to understand what that antibody response means in terms of immunity. But right now, an antibody response does not mean immunity to reinfection. So that is something that that is underway. So an immunity passport is not something that WHO can recommend at the present time.
They are saying that you can use it only for research.
Thank you very much for that, Maria, and we will now permit you to get on to your next series of meetings. Thank you. Whilst I think the Secretary have the...
On the specific question regarding availability of testing, we have formed 3 purchasing consortia made up of a number of different partners. And through this, we are trying to aggregate volumes, secure funding, and approach manufacturers to try and get a negotiated allocation. In diagnostics, we have now increased sources and are negotiating with 5 vendors of high throughput tests. We've added sources to the manual PCR, so we have 5 now, up from 1 that we had a few weeks ago. And then we have the Cepheid GenX platform that we're also in negotiations with. Current status of that is that we've secured good quantities at lower prices than others are in the process of paying. And we're in the process of putting the financing together to then be able to purchase and distribute that. The allocation process will be ongoing, very much based on gaps, on the equipment that countries may have already in place. So we do want to match assays with machines that can run them, and we'll proceed from there. In PPE, we continue through that consortium, both mix of direct sourcing from China, from Chinese manufacturers, but also collaboration with UNICEF, the launching of a global tender. It's a rolling tender open until end of June, and we're seeing what the responses are from various different companies to get a sense of how much of the market is unblocking. And then the third consortia around the provision of specific biomedical equipment, it's still in the process of putting their requests together. And that's really going to be looking at, and I think there's still some discussion around the mix of, the correct mix of oxygen concentration, ventilation, CPAP, and where those should be bought and targeted. And again, around that, there is the need to approach some manufacturers directly with funding pledges in order to be able to secure quantities. So work is ongoing through those 3 forums. At the same time, we have launched a request platform in the partners portal, and that we're hoping to issue guidance and instruction around by the end of this week. That will allow us to start looking a little bit more analysis on the demand numbers. The aim being we try to reduce demand amplification, repeated requests and duplication, and really get an idea of what the needs are. So we'll be sending guidance on that, and the benefits of potentially going through such a mechanism is really being able to, at country level, aggregate and prioritize the need. And then through the buying consortia, really looking at collaborative procurement in order to give us some market position in a period of very high demand. The allocation methodology that we agree on with the technical input from WHO, and then finally the singular delivery platform through the partnership with WFP in order to navigate the issues we're finding with the deterioration of the international transport system. So it's within those 4 principles that we're hoping to solve this particular problem. Thank you.
Thank you very much, Paul. Jude, I'd now like to go back and give the remaining member states an opportunity to ask their questions. I recognise, Excellencies, colleagues, that we have again gone over time. This does show the amount of interest, I think, in this very important issue, and the engagement with you ministers, other senior colleagues from capitals is particularly important and especially valuable. So if you are able to bear with us for another 15 or 20 minutes, we will endeavour to get through the remaining questions and provide answers. And I have not neglected Bhutan, that you had some specific questions of those countries who have already presented this morning on rapid test kits, and we will afford the opportunity to come back to those presenters after this round. Jude, if I could now give the floor back to you. Thank you.
Thank you, Chair. Recognize Russian Federation, China, and Madagascar. Russian Federation, you have the floor, please.
The Russian Federation is undertaking large-scale measures to combat coronavirus. At the moment, we have around 62,000 confirmed cases. Well, in order to combat this, we are implementing comprehensive national health system and large-scale monitoring. Our task is to prevent a sharp rise in cases by containing the transmission of coronavirus, and particularly focusing on the elderly. We have implemented a lockdown of sorts, and we are carrying out measures to restrict transport and also large-scale events, and we're also implementing remote education in educational systems. And we are increasing the amount of testing that we are carrying out. There are specialists who are working on this in a timely manner. The Ministry of Health has carried out preparedness and response activities, and we are looking very closely at the development of coronavirus. We are working with medical organizations and staff, and we are looking at the issue of human resources. So across the country, we have specialized centers to target patients, and we are looking at people with underlying health conditions. So we are a regional center for dealing with this COVID-19, and we are working with the WHO and also with other partners, such as the US. We have specialized systems for diagnosing COVID-19, and we are working with around 30 states in this area. And we have also taken decisions to work in solidarity with other states. And I would like to note that this is a very serious challenge to the national health system, and joint efforts with the WHO will be of vital importance. Thank you for your attention.
Thank you, Russian Federation. I recognize China. You have the floor, please.
谢谢主持人，
Thank you.
感谢各位。
I give my thanks to all the ministers for your presentations. Also thank Dr. Tedros and the Secretariat in your organization and efforts for organizing these briefings. In the past 24 hours, China has reported 10 new confirmed cases and no new deaths. There are now 959 confirmed cases in the country. Against the current backdrop, China will continue to conduct positive measures to enhance our outcomes in this regard, also to enhance international cooperation and help countries in need. We'll continue to support the WHO in its leading and playing a leading role in the international cooperation. Not long ago, we have adopted $20 billion. Now I would like to take this opportunity to announce that China will contribute additional $30 million to WHO to support the organization continue to play a leading role in the global fight against the epidemic, as well as supporting the construction of public health system in developing countries. The virus knows no borders, and we need to demonstrate solidarity in this regard. China is willing to contribute to fight against this epidemic. Thank you.
Thank you very much, China. Madagascar, you have the floor, please.
Thank you very much, Jude, and thank you for those countries who have just asked further questions and made comment. Before I return back to the Secretariat, I would now like to hand the floor back to the countries which gave the presentation earlier this afternoon, in order to address any of the matters which were requested of you, in particular the specific request from Bhutan on experience with rapid test kits. Jude, you'd have to help me here, I think, please. I'm not sure which ministers or ministries are still online from our 6 presenters. If I could ask Jude to run through and afford the opportunity to those countries in order if they have any comment.
Thank you, Chair. We understand that the minister from Sweden has had to leave. We do have the minister of Iran still with us. South Africa has had to leave as well. And we do have Fiji. And yeah, I think we have Chile as well, who's come back from the meeting. So we do have 3 ministers online. Perhaps I'll yield the floor to Iran.
Well, thank you very much for giving us the floor. This is from the Ministry of Health of Iran. As mentioned by our minister, Iran really has reached a stage of the self-sufficiency in producing the PPE, and soon we will be able to export the PPE, disinfectant, and ventilators to other countries. Regarding the U.S. point of view on humanitarian exceptions, unfortunately, this is not the case. Unlawful and unilateral U.S. sanctions are in place, even on pharmaceutical and COVID-19 related equipment, such as PCR and diagnostics. The sanction has definitely affected social, economic, and now health status of the people who should stay at home without any income. The U.S. administration has devised its sanction to kill and harass the ordinary people in these circumstances without discrimination. This should be removed in practice, not in kind. Thank you very much.
Thank you, sir. May I recall and seek your understanding that the aim of these information sessions is to focus on purely technical issues. And whilst we realise that there are related non-technical issues, and the Secretariat is working on ways to find space for them in an appropriate manner, we really would appreciate that the purpose of these information sessions, and particularly given that we are limited in time, have gone over time, and could ask that we all focus purely on the technical matters at hand. In that light, I would like now to provide the floor to Fiji. If I could please then give the floor to Dr. Wanana Betty. You have the floor, sir.
Thank you, Chair. We in Fiji use the RT-PCR test in our molecular lab, Fiji Center for Disease Control. In terms of the rapid test, we do not use the rapid test as of the moment, sharing the concerns that have been raised by the technical expert at WHO. We are waiting for the WHO approved gene expert test that we are hopeful will be in the country within the next 6 weeks to 2 months, based on productions that are being happening at the moment at the manufacturing plant in which it's happening. So when that does come through, then we'll have it in Fiji. We're looking at about 30,000 using the gene expert. But at the moment, going back to the original question, no, we don't do rapid tests. We do RT-PCR, and we are waiting for the WHO approved gene expert test, which will be available in Fiji in 2 months' time. Thank you.
Thank you very much, Honourable Minister. Judy, if I could hand the floor back to you. You understand who is online now from the presenters and could react to...
We understand that the Ministry of Health of India is online.
India, you have the floor. If I could indulge that the responses be as succinct as possible in order for us to finish in the remaining few minutes and ensure that we get to respond to all the questions that have been raised. India, you have the floor. Thank you, sir.
I'll just briefly comment on the two issues that have been raised by my colleague ministers. One is about tests. We are, in fact, for diagnosis purpose, we are using the RT-PCR test, and also we are in the process of, in fact, using the WHO approved gene expert test also. We are also procuring cartridges for that also for the future times. But regarding the antibody test, we had recently procured kits from China, and then we had distributed them to the whole country, and we had started using this antibody test in some of our hotspot areas, mainly to basically for the purpose of surveillance and for the epidemiological studies. But in the initial stages itself, we have received a varied response from the various states. At some places it has been very minimal, I would say, success. Yes, some states are saying that they are getting only just about 5 to 10% results. At other places it's something like 70%. So right now we have asked everybody to stop for the moment, and ICMR itself is basically studying the controlled testing at a number of places in the country, and within, I think by today evening we should be able to derive the results. So in fact we are in a stage of a bit of a dilemma, whether it is due to the bad quality of the kits or whether it is right now the validity of the test or its usefulness is not really established. The WHO is also non-committal on the subject till now. Today also you have said you can use them for some, you can say, science, research, epidemiological study, etc. So that's the position about it. Regarding the PPEs also it was raised. So I may tell you that earlier we were not making these PPEs in India because the cloth for this was imported from China, and because of the disturbance there we couldn't procure that. But this whole episode has come as a blessing in disguise for India. Our Ministry of Textiles and our Health Ministry, they had in fact worked together, and right now we have in the last 2 months got ready more than 100 manufacturers of PPE in the country itself. And yesterday itself we prepared 1 lakh PPE kits in a single day. So that part of the problem for us is resolved, and maybe if there is a need, we can probably help our neighboring countries like Bhutan in times of need. That's what I can say. Thank you.
Thank you very much, Honourable Minister. I think that will be it for now. Thank you.
Thank you very much, colleagues. DG, would you like to say, or Maria, do you have any final comments on anything you've heard?
Thank you very much. Only to clarify, thank you for raising these issues and again, because I think it is confusing. There's so many tests that are out there. But just to be clear, we recommend the use of molecular tests, the PCR tests, for surveillance purposes and for clinical care. But for the serology, for the serologic assays, although there are a large number of tests that are out there, they still require validation. And at the present time, we do not recommend the use of the rapid diagnostic serologic tests for surveillance purposes. We do recommend their use in research because we do need to better understand how they are, how they perform. We do have guidance online, and we can send it through the Secretariat to the health ministers to ensure that you have that at hand.
Okay, thank you. Thank you very much, Maria. This is Tedros, honorable ministers and excellencies, friends. Especially on this last particular issue regarding the rapid test and serology, we will send you directly some of our advices, and then we can hear from you also based on your experience and take it from there. And I would like to again thank Minister Zwelini from South Africa, Minister Maxim from Chile, Minister Namaki from Iran, Minister Halangren from Sweden, and Minister Vardhan from India, and Minister Wakenbete from Fiji. Thank you so much indeed for your presentations. I know many countries have gained some experience from what, or best practice from what you're doing. And if you can agree, we have some of the presentations, but those of you who haven't sent us, please send us your presentations and we will share it with all countries. Then maybe some final thoughts. One, on the solidarity trial. As you know, we're testing 4 medicines, and many countries have already joined. And anyone who would like to join the solidarity trial, you're welcome. The other is what you raised, shortage of PPE. We're working with the private sector. We're working with the International Chamber of Commerce. The way forward is increasing production. And many countries are already repurposing their industries to produce PPEs, and we're encouraging that. That's what will help actually in addressing the shortage. But at the same time, we have the UN-wide supply chain task force that's being led by WHO and the World Food Program, all UN agencies, UNICEF and others joining, and even non-UN agencies. And we're giving priority to countries who need our support. And the solidarity flights have already started, and we will continue to support countries through that task force or the solidarity flights. The last part is the vaccines. As you know, we don't have a vaccine now, but there are studies underway. But we believe that we should do 2 things. One is accelerating the development of vaccine, and second is, before even we have the vaccine, to ensure equitable distribution or access to all who need it. If we cannot address this issue ahead of time, you remember what happened with H1N1, the same problem could happen. The haves can have the vaccine, the have-nots will not be able to have the vaccine. And we have been saying solidarity, so we need solidarity also when we get new medicine or when we get new vaccines. But when I say this, it means we will give it our best, the whole world will give it its best to accelerate the development, and then the access issue. But we need to be also very careful, and it's a cautious optimism whether we can have the vaccine as soon as possible or not. So the focus now should be on what you're doing to suppress and control this virus with whatever tools we have at hand now. So while investing in vaccines, we have to use the tools we have to the maximum. And as you all said, the community-based approach, and especially ensuring trust and making this fight everybody's business and mobilizing the whole community is very important. And as South Africa and other countries have pointed out, the use of frontline health workers that are actually acting as a bridge with the community will be very, very important. So with that, thank you so much again to all of you, all who have attended. Many of you have said this and sent me actually direct messages, including direct messages, saying this kind of forum is very important to share experience. So we will continue to have ministerial level presentations, member state sessions, so that we can share your experience and also, create the opportunity to learn from each other. So thank you so much, and look forward to seeing you in our next session. All the very best from my side. Thank you.
देखिए, आज विश्व स्वास्थ्य संगठन का जो हेडक्वार्टर्स है जेनीवा में, उन्होंने सारे दुनिया के स्वास्थ्य मंत्रियों का वीडियो कॉन्फ्रेंस के माध्यम से अभी पिछले 2.5 घंटे से मैं एक मीटिंग की, और उसमें उन्होंने दुनिया के 6 रीजन्स के 6 देशों को प्रेजेंटेशन करने के लिए कहा था। और साउथ ईस्ट एशिया रीजन की तरफ से उन्होंने भारत को, जो कोविड-19 के संदर्भ में भारत ने पहल की है और हम आज कहाँ खड़े हैं, इसका प्रेजेंटेशन करने के लिए कहा था। वो मैंने आज सारे दुनिया के सामने, सभी हेल्थ मिनिस्टर्स के सामने यहाँ से प्रेजेंटेशन किया है, और हमने दुनिया को ये बताया है कि किस प्रकार से भारत ने अपना पहला केस 30 जनवरी को आने से बहुत पहले 8 जनवरी को ही 24 घंटे में, जब चाइना ने रिपोर्ट किया कोरोना वायरस के बारे में, उसके 24 घंटे में हमने अपने टेक्निकल एक्सपर्ट्स की मीटिंग की यहाँ स्वास्थ्य मंत्रालय में। उसके 13 दिन पहले ही हमने 17 जनवरी को सारे स्टेट्स को डिटेल्ड हेल्थ की एडवाइजरीज दी, और कम्युनिटी सर्वेलेंस हमने देश के अंदर जो है शुरू कर दिया। हमने अपने एयरपोर्ट्स पर स्क्रीनिंग शुरू कर दी। जब 600 केसेस हुए थे, तब हमने देश में प्रधानमंत्री जी के आह्वान पर नेशनल लॉकडाउन पहली वाला शुरू किया, और अभी तो उसका सेकंड पार्ट भी जो है हुआ। किस प्रकार से सारे देश को वॉलंटरली इस मूवमेंट में जोड़ने के लिए, कोविड के ख़िलाफ़ लड़ाई में कैसे प्रधानमंत्री जी ने जनता कर्फ्यू को घोषित किया, और कैसे हमने एक लैब से अपने देश की जो लैब की कैपेसिटी है उसको 230 सरकारी लैब्स तक और 80 से ज़्यादा प्राइवेट लैब्स तक और 16,000 से ज़्यादा कलेक्शन सेंटर्स तक हमने विकसित किया। आज 5 लाख से ज़्यादा हम टेस्ट कर चुके हैं। एक दिन में 30,000 35,000 हम टेस्ट कर रहे हैं। हमारी रोज़ की 55,000 की कैपेसिटी हो गई है। हमने बताया कि दुनिया के मुकाबले हमारा जो मोर्टालिटी रेट है वो केवल 3% है, और हमारा जो केसेस का डबलिंग रेट है वो भी दुनिया से काफ़ी बेहतर है। वो आज 8.78% के आसपास है। हमने दुनिया को ये भी बताया कि हम किस प्रकार से विज्ञान के माध्यम से इस कोविड-19 के ख़िलाफ़ लड़ाई को लड़ने की कोशिश कर रहे हैं। हमने वायरस को आइसोलेट कर लिया है। हम वैक्सीन को बनाने की दिशा में आगे चल पड़े हैं। हम WHO सॉलिडेरिटी ट्रायल में पार्टिसिपेट कर रहे हैं। हम कोविड-19 के वायरस की जेनेटिक सीक्वेंसिंग भी कर रहे हैं। हम अपनी साइंस की लेबॉर्ट्रीज़ के माध्यम से टेस्ट को बहुत ही कम समय में कर पाने के लिए हमने उसके लिए भी जो है एक स्पेसिफिक टूल, एक लैंप जो है वो विकसित कर दिया है। और इसके साथ साथ नए स्टार्टअप्स, नए एंटरप्रेन्योर्स, नए यंग रिसर्चर्स को भी हम सब प्रकार का सहयोग कर रहे हैं। हॉस्पिटल जो असिस्टेड जिसे कहते हैं डिवाइसेस बनाने के लिए, वेंटिलेटर्स भारत के अंदर बनाने के लिए, जो PPE किट हमारे भारत में होता नहीं था, हम बनाते नहीं थे। आज हमने इसी दौरान 100 से ज़्यादा देश में मैन्युफैक्चरर्स को तैयार कर दिया है और पिछले 2 दिनों में हर रोज़ हम 1 लाख तक किट्स जो है केवल भारत में बना रहे हैं। तो हमने सारे दुनिया के लोगों को बताया है कि आज हम देश में कहाँ कहाँ बीमारी है वो हमें बड़े स्पष्ट रूप में पता है और उस बीमारी से कैसे लड़ना है वो भी हमें पता है और उस लड़ाई को हम पूरी स्ट्रैटेजी के साथ, मेटिकुलस प्रिसीजन के साथ हम उसको लड़ रहे हैं। हम स्टेट्स की मदद कर रहे हैं, उनकी हैंड होल्डिंग कर रहे हैं, अपने एक्सपर्ट्स को यहाँ से भेज रहे हैं। प्रधानमंत्री जी का हम इसमें गाइडेंस, आशीर्वाद हम लगातार ले रहे हैं और सारे देश को हमने हॉटस्पॉट्स में, नॉन हॉटस्पॉट डिस्ट्रिक्ट्स में और ऐसे डिस्ट्रिक्ट्स में जहाँ कभी कोई केस हुआ नहीं है उसमें डिवाइड किया है और एक ग्रेडेड प्रीएम्प्टिव और प्रोएक्टिव स्ट्रैटेजी के तहत हम कोविड-19 के ख़िलाफ़ जो है लड़ाई लड़ रहे हैं। हमें पूरा विश्वास है कि हम आने वाले समय में इस बीमारी के ऊपर ठीक प्रकार से सफलता प्राप्त करेंगे। लोगों से हम सोशल डिस्टेंसिंग को एक सोशल वैक्सीन के रूप में इस्तेमाल करने के लिए हम कह रहे हैं। ये भी हमने अपने इस इंटरनेशनल फोरम पर बताया है और बाद में जो दूसरे देशों के कोई सवाल थे उन सवालों का भी हमने उत्तर दिया है।
सर, जो दुनिया के देशों का क्या रिस्पॉन्स रहा है, जो भारत के जो एफर्ट रहे हैं उस दुनिया के देशों का क्या रिस्पॉन्स रहा है?
नहीं, देखिए तो भारत के प्रयासों की तो विश्व स्वास्थ्य संगठन वो औपचारिक तौर पर कई बार सराहना कर चुका है और लगातार जो है पहले भी साउथ ईस्ट एशिया के फोरम पर भी, इससे पहले भी इसी फोरम पर और आज तो WHO ने भारत को जो सारे दुनिया के देशों के सामने अपना प्रेजेंटेशन करने के लिए कहा तो साउथ ईस्ट एशिया की तरफ से हमने यहाँ प्रेजेंटेशन अपने देश की जो भी पहले दिन से लेकर और आज तक की स्ट्रैटेजी है उसके बारे में किया है।
Thank you very much. Today I think we are very pleased that the Minister of Health, His Excellency Vardhan, he was sharing the experience at a global forum. Our Director General was over there, our regional director, but all the ministers in the world were also connected. And I think what's so important also here in India is that what the world can learn from India is that India took it seriously from the onset. And what India also did, it took very strong intervention and measurements from the onset, in the early part of the outbreak. And I think you have been hearing about this flattening of the curve, how important it is, because you do not want the health system to collapse. Now, this early intervention is very important to keep it flat. I think India, in that sense, I think has been sharing those lessons globally, and I think that's very important. But of course, I think we're still in the outbreak itself, and I think in that sense, India hasn't stopped over there, and it is now also continuously looking to start even better preparing the health sector and making sure that we are on top of this outbreak. Surveillance will be extremely important to have an understanding where the outbreak is, making sure that you know where the patients are, but also that you then do the other part, where India, I think, has also got a lot of strength in the past, is making sure that you then, after the testing, that you do the contact tracing, that you make sure that you understood where the patient might be in touch with, and are making sure that those people are also isolated and very clearly followed up. As WHO, we feel also very proud that we're supporting the government in this area, especially our team in the field. They are also helping and supporting the IDSP, this Integrated Disease Surveillance Program, and that the people, and that we are supporting them in the contact tracing and the follow-up. That will be one of the major keys, because what you would like to do, you would like to keep the patients outside the hospital. Yeah, you would like to make sure that you do all the things that you can to make sure that the outbreak doesn't expand.